all. I, Dr. Madhura, on behalf of Pune Obstetrics and Gynec Society, welcome all of you for the Cutting Edge webinar. So today we are doing it with Allahabad Society. So ma'am, I want to ask you, should we say Prayagraj or Allahabad?
Actually, the society is Allahabad Society only because we are registered as AOGS.
Acha. Okay.
And we don't want to make it POGS. So, but actually it's Prayagraj now.
Okay.
But we insist on saying Allahabad.
But we'll say Allahabad Society. Okay. So we are doing it with Allahabad Society today, and we are privileged to have all eminent faculties with us. So just in short, a brief about the Cutting Edge webinar. So we started this webinar. It was a brainchild of Dr. Meenu Agarwal, madam. So we've been doing this every Tuesday evening, 4 to 5 p.m. With a very crisp topics related to infertility, ultrasound, and of course, intrapartum care. So we've been doing it with different societies all over the country, and it's been very popular amongst students and other faculty. So I welcome you all for the same. So Dr. Meenu ma'am will be just joining us in some time. I welcome Dr. Aarti Nimkar ma'am, who is the president of POGS for the present term, and I request her to say a few words.
Yeah, I am very happy to welcome you all from the Allahabad Society. I welcome Dr. Ranjana Khanna as a guest of honor and Archana Verma also. They are the past vice president of the FOXY. Welcome both ma'am to the Cutting Edge webinar, and it will be our honor to you have as a guest of honor. And our first session is intrapartum care for the joyful motherhood, and our speaker is the Dr. Veena Gupta, professor of the OBGYN in the MLN Medical College, Prayagraj. And chairperson for that session are the Dr. Shubha Pandey, President OBGYN Allahabad Society, and Dr. Kumkum Tandon is a senior gynecologist and obstetrician in the Central Railway, Prayagraj. For second session will be Meenu will deliver a lecture on the main infertility. What is a gynecologist? The chairperson for that is Manish Majpe. Everybody knows the Manish Majpe. He is the past of the chairperson of the medical legal committee, and Dr. Kumar Jaiswal madam.
Uma, mute
I
kar lo.
wish me all for this. Yeah.
Mute kar le beta.
Somebody.
Namaskar, ma'am. Everybody.
And I ask my MOC to start the webinar.
Thank you, ma'am.
Thank you very much.
Thank you, ma'am.
तो मैं बैठी तो हूँ.
Yes. So before beginning the program, we would like to take blessings from the Almighty. I request the team to play a short prayer song. Can we have the prayer song?
Any mute Mr.
Prasad is not there, I think, from BSV.
Prasad, yeah.
Who else is there from BSV?
I think the RX event person.
Yeah.
Who is there? RX.
you have done during your vice presidentship, madam. And madam is also founder president ISOPAP Prayagraj in 2021, ICOG Governing Council member. She has been executive member of National ISOPAP. She's president AOGS 2013 to 2017. And she has been organizing chairperson of National Foxy Conferences, Scientific Sangam Prayagraj 2023. I think it was a very well-known conference, ma'am. We heard a lot about it. And she has also done BOH Trilogy Delhi 2017, organizing secretary of National Foxy Conference in 2016, and she has been faculty at various national, international on fronts, and she has been co-convener of Foxy GCPR on epilepsy in pregnancy. Madam has received many national and awards like Foxy Achievers Award, Foxy Dira Award, Foxy Dr. DK Tank Award, Foxy Smriti Milan Award, Save the Girl Child. This was at AICOG 2013. So we are truly honored, ma'am, and we request you to give us your blessings and few wishes. And I would also like to declare that these webinars we've been doing, these are conceptualized by Dr. Meenu Agarwal, and Dr. Meenu Agarwal is going for the post of Vice President Foxy. So we solicit everybody's support for her Vice Presidentship. Welcome, ma'am.
Thank you so much. A big thank you to the Pune Society and Dr. Meenu Agarwal for the invite. First of all, it gives me great pleasure to meet the president of Pune Society, Dr. Aarti. I can't see the secretary, Dr. Meenakshi, and past chairperson of Foxy, Dr. Vaishali Chavan. I think you were perinatology committee. And now we have another chairperson from Pune, that is Charulata. So Pune, as I was saying, is a very, very dynamic society. And we have the president-elect Foxy and the elect chairman of ICOG also from Pune. And Dr. Manish is saying that he is going to be the president of the Pune Society. And we also have the president of the Amog Society from here. So it's a great achievement for a society of this stature. And it gives me great pleasure to be here. Dr. Meenu Agarwal, I know, is contesting for Vice President Foxy. My best wishes to her. And as you all know that I am contesting for the post of president, you have just said Vaishali. So I would request all of you for your vote and support. And I come from the holy city of Prayagraj. And you have spoken my CV in so much detail. I'm indebted to you, Vaishali. And I wish this webinar great success. The topics are very good and very interesting. And looking forward to being with you all in person too. Thank you.
Thank you, ma'am. Thank you for those kind words. So I think we can move ahead with the first session, for which I would like to invite our esteemed chairpersons, Dr. Shubha Pandey, who's the president of Allahabad Society, and Dr. Kumkum. I think she will be joining in another 2-3 minutes. So I request, I think Amol sir is also busy today. I would just like to introduce Dr. Shubha madam. Just give me 1 minute. I'll share the slide because I think they are not there. I'll share the slide.
Yeah.
Good evening. Can you hear me?
Yes, ma'am. Good evening.
Yeah.
Can you hear me?
Yes, good evening, ma'am. Just a moment. Dr. Madhura will introduce you. Formal introduction.
Yes, ma'am. Is my screen seen?
Yeah.
Yeah. So I would like to introduce Dr. Shubha Pandey, madam. She's the head of obstetrics and gynecology at Kamla Nehru Memorial Hospital, Prayagraj, and she's the current president of OBGYN Society of Prayagraj. She is a renowned professional with an experience of more than 40 years in the field of obstetrics and gynecology. She has a special contribution in the field of infertility, high-risk pregnancy, cancer screening programs, and geriatric problems. She's a teacher and trainer of DNB. I'll just finish in 1 minute. Of DNB and DGO students, and she's also an examiner of DNB and non-DGO. Welcome, ma'am. Dr. Kumkum is yet to join. So, ma'am, you can continue with the session. I request you to introduce our first speaker, who is Dr. Veena Gupta.
Shubha, unmute yourself. Shubha, unmute. You're mute, huh?
Will you
Yeah.
will you send a slide? Will you
Yes.
display a slide, please?
Yes, ma'am. 1 minute.
Dr. Kumkum Tandon? Whom am I
Yes.
supposed? Veena Gupta.
Dr. Veena Gupta.
Veena.
Yes, ma'am.
Dr. Veena Gupta is a dear friend of mine. She's also from Allahabad. She is professor in medical college. She's a professor in medical college over here with 23 years of work experience. And she has been the organizing secretary of UPCon 2006 and has many research papers in national and international journals. Welcome, Dr. Veena.
Thank you, ma'am, for your kind words. Now I can say
Ma'am,
good evening to all.
so sorry to interrupt. Yeah, Dr. Meenu has joined. I was just going to inform the event person to take Dr.
okay.
Meenu. She's joined. Sorry for interruption. Ma'am. Please go on.
Everyone, Vaishali, Dr. Veena Gupta, Madam, Ranjana, Madam.
Meenu, I've already wished you best of luck. And it's your turn to wish me also best of luck.
Madam, yes. Hello.
Since we are sailing in the same boat.
Absolutely, madam. Absolutely. Thank you, Veena, madam, for this nice lecture that you're going to give. And thank you, Allahabad, or the Pragya Raj Society that now it is called. So thank you very much for associating with Pune Obstetrics and Gynecological Society. And thank you, Ranjana madam, again for joining as a chief guest. Thank you, Shubha madam. Thank you, Uma madam. And Manish, nice to see you. You are a relative. So nice to see you. Thank you for joining. And thank you, Veena Gupta madam, for giving, for being a faculty and giving this talk on joyful motherhood. So we are looking forward to this particular webinar, and I think we can start with the talk. I will not come in between you and the doctors who have joined in. Thank you.
Should I start, madam? Good evening, everybody. I think now it's the evening tea time, so I can say good evening. First of all, I will congratulate Pune Obstetrics and Gynecological Society for organizing such a beautiful seminar on, intrapartum care kind of cutting edge. Then my topic is intrapartum care. As you already know,
Ma'am, shall I interrupt you for 1 minute? The other chairperson,
ma'am.
Dr. Kumkum madam, has also joined. Shall we just introduce her in a minute and then you can start, ma'am?
Sure.
Chalega?
Sure.
Yes, ma'am.
Yeah.
So I would like to introduce Dr. Kumkum Tandon, madam. She is also from Allahabad. She's currently working as a consultant in obstetrics and gynecology. She's actively doing surgical practice also. She has worked as a chief obstetrician and gynecologist at Central Hospitals in a Central Railway Hospital at Prayagraj. She's worked as a chief health director, senior administrative grade at headquarter, North Central Railway, Prayagraj. I thank you, ma'am, for joining us today and welcome you. Yes, ma'am. Thank you.
Thank you, Shubha ma'am, for your kind words. Now, I should say good evening to all because now evening time has started. First of all, I will congratulate Pune Obstetrics and Gynecological Society for arranging this webinar. And I'm also thankful to the organizers for giving me this opportunity to share my views on intrapartum care. As you all know, that giving birth to a child is a unique experience for a mother in her lifetime. The process of labor have got great psychological, emotional, and social impact to the woman and her family. She experiences stress, physical pain, and fear of dangers. So the duty of a care provider is to be tactful, sensitive, and respectful to her. And then here comes the concept of intrapartum care. Now, the intrapartum period is a period from the onset of labor to the time of delivery. The concept of intrapartum care rests on three pillars, that is, providing optimal pain relief, that is by the use of analgesics and antispasmodics, ensuring adequate uterine contractions like active management of labor, and close clinical monitoring of labor events, that is maintaining a partogram. Now come to this intrapartum care was the indigenously developed protocol for labor management by Daftari et al. From 1977, 2001 and 2003, who developed this protocol with the objective of providing pain relief during labor and reaching the goals of safe motherhood by optimizing obstetrical outcome. Now comes about the active management of labor. It was a concept which was advanced by the Irish school. In 1973, O'Driscoll and his colleagues reported on the advantages of active management of labor, which results in shorter labors, improved obstetrical outcome, and lower rate of the cesarean section. Why active management? Because the active management will prevent infection. It will prevent maternal exhaustion, because for prolonged labor will lead to the mother exhaustion. That will lead to the dehydration and ketosis, then delusion in mothers and the fetal distress. So the active management of labor is to cut short the active stage of labor, first stage as well as the second stage. Now, maintaining a partograph. You all know about the partograph. It is the series of events which is plotted on a piece of paper. There is an alert line and the action line. Here, the dilatation of the cervix is taken as a standard 1 centimeter per hour, and an alert line is drawn. And 4 hours parallel to the alert line, there is an action line. Suppose the partograph goes towards the left of the alert line, then it will lead to a successful delivery. But if it is between the zone 2, I mean between the alert line and the action line, you all know we have to reassess the patient. But if it is below, right to the action line, then it means some intervention has to be done. The pregnancy has to be terminated. Now, how to select a patient for intrapartum protocol? There should be no identifying medical or obstetrical complications. The patient should be a primigravida with significant pregnancy, with cephalic presentation, and with the spontaneous onset of labor. The gestational maturity should be 37 to 41 weeks. On admission, a non-stress should be done, and that should be reactive. It means the fetal is reactive and there is no fetal distress. The patient should be uterus and the cervix should be 50% effaced. Then again, the selection criteria are primary, as I've already told you. It can be a multi also, more than 38 weeks. The low risk patient, there should be no high risk factor. There should be presence of anesthetist and neonatologist, because we can, once you are giving the obstetrical analgesia or epidural analgesia, the anesthetist should be present. The consent of the patient should be taken, and it should be started during the active phase of labor. Means when the cervix is dilated 3 or 4 centimeters and it is effaced. Now, what are the patients that are not to be considered? They are high risk cases like antepartum hemorrhage, preeclampsia, diabetes complicating pregnancy, polyhydramnios, oligohydramnios, cephalopelvic disproportion, malpresentations, and premature rupture of membranes. Now, about the medication protocol for intrapartum care. It starts when the patient enters the active phase of labor. It means the cervix is 3 centimeter dilated, effacement is more than 50%. The uterine contractions, they come at a frequency of at least 3 per 10 minutes, lasting for 35 to 40 seconds. The head should be engaged, and there should be no clinical suspicion of CPD, because the patient will not go for vaginal delivery. And the patient may have shown, means the signs of labor should be there already. What are the medications used in intrapartum care. As per protocol, a combination of drugs are used to provide effective pain relief, that is labor analgesia, coupled with antispasmodic drugs, which help in cervical softening, yielding and dilatation to moderate driving force. What is the advantage? The advantage of protocol will be that it will provide the benefits of drug analysis, while at the same time it will restrict the doses of drugs to the minimal amounts so that there is no risk factor to the fetus or the mother, and it will help in achieving the progressive labor in the safe vaginal delivery. What is the protocol? The intrapartum protocol includes just start an IV infusion line with 5% ringer lactate solution at the rate of 20 drops per minute. Ensure that the pains are optimal, means 3 to 4 contractions per 10 minutes. If necessary, you can add 2 units of oxytocin to enhance the uterine contraction or to augment the labor to the drip, or you can give a tablet of Chymocross orally every hour to ensure optimal pace. Then what next? Dilute an ampule of 30 mg of pentajocin or Fortwin with a diluent like normal saline or distilled water in 10 ml of saline. And similarly, dilute an ampule of diazepam also in 10 ml of dilute. Administer 1/5 of each drug, means 6 mg of pentajocin, Fortwin, and 2 mg of diazepam. Slowly should be given in bolus form through the infusion line. Then again, start and I will give it 5%. Ensure that the pains are optimal. If not, give 2 units of syntocinon to the drip, or Chymocross tablet should be given orally to ensure the optimal pain. Observe the progress of labor by charting maternal and fetal parameters every hour or earlier if indicated. Means if the contractions are very severe, if there is spot collapse, if there is rupture of membrane, then you can assess early and assess the progress of labor on basis of cervical dilatation and descent of fetal head. As we do in Patoga, we plot the dilatation and we plot the descent of the fetal head. When the patient is in advanced labor, she is progressing well, the fetal head is pressing down on the pelvic floor. The patient starts complaining of severe pain because there are bearing down pains now, and the patient is having a sensation of bearing down. At this time, the cervix is almost fully dilated, that is 7 to 8 centimeters, and this is the time when you can administer injection ketamine for the pain relief if it is required. Now the anesthesia, you all know the proven obstetrical analgesia is epidural anesthesia. But epidural anesthesia can be given only in the highly equipped centers. But when the epidural analgesia cannot be provided, like in low resource settings, like in developing countries where the facilities for epidural anesthesia are not available, like in Prague, we don't have the facility for epidural. So Tramadol can be given. It is an opioid analgesic which can be used as a labor analgesic. You all know Tramadol can be given 50 to 100 milligram. It has got a 2 ml ampule. 1 ampule can be given to the patient. It has got side effects, can be vomiting, so you can give antiemetic also. Then you can give ketamine also. It is a dissociative anesthetic and it is gaining popularity as it proves excellent pain relief to the patient and the patient's satisfaction. Now, what is level of analgesia? How can you assess? How can you scale it? 0 means there is no pain relief. 1 means mild pain relief. 2 is moderate pain relief. And 3 is excellent pain relief. Now, there was a study where the 2 groups were compared. One was the study group in which the program labor was conducted, and the second was the control group. In each group, 200 patients were taken for vaginal delivery. And you see, in 176 patients in program labor, we had vaginal delivery, and 162 in controls. Spontaneous assisted delivery, you can see the parameters are almost equal. But what is the difference? You can see the difference is in the mean duration of active phase of labor, the mean rate of cervical dilatation, the mean duration of second stage of labor, and the pain relief. You see the mean duration of active phase of labor was 3.5 hours in program labor, while it was 5.2 in control group. The mean rate of cervical dilatation was 2.5 centimeter, and here it was 1.2 centimeter. You just see the comparison between the pain relief. The excellent pain relief was there in the program labor, 24%, and substantial relief in 62%, while it was nil in control. Substantial relief was 32, I mean almost half of the control group, case group. Then, and there was no pain relief in control group. So this shows how effective is the analgesia. The table 2 here shows you the clinical evidence of intrapartum care. The rate of cervical dilatation was 1.72 centimeters in cases and 1.23 centimeters per hour in control. It was significantly faster in cases. Duration of first stage of labor, the active phase is cut down. The second stage is cut down. Although the third stage of labor was same in both the groups. And there was statistically significant difference in the duration of first and second stage of labor. Pain relief score, you can just see the table. There was excellent pain relief in the control group, in the cases, study group, as compared to the control group. And it was significant. About the complications, of course, the complications will be more in the study group because of the drugs that in the form of nausea, vomiting, and drowsiness, which were lower in the control group. So, what are the results? The rate of cervical dilatation was 1.72 centimeter per hour in cases and 1.27 per hour in centimeter per hour in control. The duration of active phase of labor was significantly reduced. The duration of second stage of labor was 27.4 minutes in cases. It was also reduced. Majority of the patient in both groups delivered vaginally. There was no difference. 86% of the study group patients have pain relief as compared to 22 patients. And this is the significant difference. And it is statistically significant. The cases had significantly more drug-related effect because of the drugs, and they were in the form of nausea, vomiting, drowsiness. The side effects subsided after 12 hours. There were no significant fetal and neonatal complications in both the groups. Now come to the effect of velethamide bromide. It is a apitosin. The study was conducted to investigate the effect of velethamide bromide on the length of labor. A total of 200 cases were taken, in which 57 cases were excluded because 24 underwent cesarean and 33 were given oxytocin. Both the groups were divided in nulliparous 71% and multiparous 72%, in which half of them were given received velethamide bromide, and the next group did not receive. That was the control group. Similar was in the multiparous. A single dose of 16 milligram velethamide was administered via IV route in randomly selected 35 nulliparous and 37 multiparous women. The median time from complete cervical dilatation, because it is going to affect the second stage of labor. So median time from complete cervical dilatation to the delivery was 20 minutes. Of course, there was a range 5 to 70 minutes, which was in the groups received velethamide bromide as compared to the control group where it was 25 minutes. This definitely reduced the second stage of labor. The conclusion was that the velethamide bromide significantly shortens the second stage of labor in the nulliparous woman. Now, distribution of cases in terms of side effects. You can just see the table. The side effects were not very significant in both the groups, in the apitosin group as well as in the placebo group. There was no statistically different results. Now that this table shows the adverse drug reaction with hyoscine buscopan, which we use, and velethamide apitosin for cervical dilatation during labor. A total of 130 pregnant women in the labor ward preparing for delivery were enrolled, and the data were taken from the patient, those who received hyoscine and velethamide. The patients were from the age group of 18 to 35 years, and the main age was 25.5 plus minus 4.36 years. You see, once there are the women who are less than 25 years, and the second group where the age of the woman is more than 25 years. You see that there is no difference in the adverse drug reaction in both the groups. It means age has no relation with the side effects of velethamide, and there were no life-threatening or severe forms of ADI when with hyoscine or velethamide. Now, there was a study when the rotavirine hydrochloride versus velethamide bromide in the cervical dilatation. It was a comparative study, and the distribution of cases were done according to the side effect. You see that headache and cervical tear, these are the two side effects which were more with rotavirine group, and they were less in velethamide group. The patients were divided into two groups. One group was given rotavirine, and the second group was given velethamide. All things were similar except for the headache and cervical tear, which were more in rotavirine group. So the advantages of intrapartum care, it shortens the labor with substantial pain relief, significant amnesia of painful events, the average blood loss was less, the duration of all the 3 stages of labor were markedly reduced, obstetrical management simplified, lowering of the incidence of operative deliveries, and neonatal mortality was similar in both the groups. Now, it was about the velethamide. The data which was available, velethamide is an anticholinergic drug, which is antispasmodic and antisecretory. The uses of this anticholinergic drug, it is a smooth muscle relaxant, and it hastens the dilatation of the cervix. When same is delayed during labor and as visceral antispasmodic. The dose is 8 milligram IM, 10 milligram or 10 milligram oral, and repeated as required. Then there was a study where there was a comparison of injection rotavirine and injection velethamide on duration and course of labor. And you see in this study, it was studied over a span of 2 years. 120 patients were enrolled. 60 were the control group and 60 were the study group. In those 60 study group, 30 were given rotavirine and 30 were given epidosin. And the results were compared. So it was seen that the rate of dilatation of the cervix was more in study group as compared to the control group. But it was faster in rotavirine group as compared to the epidosin. So what we say that you can shorten the first stage as well as the second stage of labor by giving the analgesia, Fortrin compost, ketamine or Camadol, whatever is available or what you can do. And then for the second stage of labor, you can give rotavirine or velethamide and epidosin. So thank you.
Thank you, Veena. Madam. It was an excellent talk. Very, very nice with all the data and all the studies. And, very nicely you explained how to cut short the labor. So I think very useful talk for all the, especially juniors, but for everyone, very, very useful. Thank you very much, madam. Thank you.
Thank you, ma'am. Thank you so much.
I think the chairperson can take over. Sorry. No. Yes, Uma madam and Shubha Pandey madam.
Kumkum madam and Shubha madam.
Yeah, Kumkum madam. Yes.
Ma'am, you would like to say something?
Ma'am, please unmute.
That was very nice. It was a very good talk, very elucidating. And it added up so much to our knowledge, how to make really labor joyful and how to cut down both the stages of labor. And they should be practiced. Mostly they are not practiced because the gynecologists are very afraid of using ketamine and tramadol. That is the practical aspect. But I think we should start using it. Even I am scared.
Ketamine should be given in a very low dose because it causes hallucinations. It should be given 0.2 milligram to 1 milligram per kg body weight in a slow IV infusion, then a slow IV bolus, and then it can be given an infusion also. But we are afraid of course, we are afraid of the side effects. So we don't dare to give the ketamine. Tramadol we give, but not the ketamine.
But ketamine is always scary. It's all we think that it is the anesthetic. We should give it, not us.
But I asked the anesthetist and he said in a slow dose it doesn't cause any of it.
Yes, they always say. So that was very nice.
Let us try.
Let us try it. Yes.
Let us try.
We should try it now. Yes. Dr. Kumkum, you
Let
want
us
to
be
add
benefited
something?
by this webinar.
Yes.
Yes.
I think we really learned it that we should be brave and try it.
Yeah, of course. But in our days, we used to give this epidosin on when it was a primary. And a tough cervix, we used to give 3 doses, repeated doses, half an hour, and sometimes it does work. But I have always noticed that giving epidosin sometimes dampens the pain. And but
Then we have
it's
to
a
give
good.
oxytocin again. We give epidosin and then we give oxytocin. And
And
then
we
we
give oxytocin, so the game keeps on going on. That's what
cycle
it
goes
is.
on.
But injection Rotavigan we give in our labor room. But of course, it causes cervical tears.
I know.
Thank you.
Thank you.
Thank you, ma'am. Thank you for that wonderful talk. Let us move ahead with the second session now. For the second session, I would like to invite our esteemed chairpersons, Dr. Manish Mathur sir and Dr. Uma Jaiswal madam. I request Dr. Vaishali ma'am to introduce both the chairpersons.
Yeah, thank you, Madhura. Before I introduce the chairperson, I would like to say, Veena ma'am, that was an excellent talk, and we really enjoyed the very practical tips you have given. Thank you for the talk. And Shubha ma'am, it has been a pleasure to connect with you and to discuss with you and plan this entire webinar.
Thank you. You were so
Yeah.
you were so worried now. You kept on reminding us. Thank you.
Because it was at a short notice and you were
Yes,
there,
yes.
and we
This
could.
is a good one. And it's an interesting topic, so we are enjoying it.
Yes, ma'am. Yes, ma'am. Thank you. So it is it gives me great honor and pleasure and happiness to introduce none other than Dr. Manish Mathur, and he is my dear colleague and friend from Pune. Like he said, he is a doctor for the doctors, because he's always there to help us all, not only in obstetric emergencies, but for any medical legal issue. Dr. Manish is there to help one and all. He is presently president-elect for Pune OBGYN Society, and he has been past vice chairperson, medical legal committee for OXY, and he is brilliant in every way. He was a gold medalist in UG, in PG. He's a born orator. I was just now telling Ranjana ma'am that the way Manish speaks and he keeps the audience in splits, he's very humorous. At the same time, he has great academic grasp and he enthralls the audience. He's a fabulous orator and very much in demand and sought after. He's a fabulous laparoscopic surgeon, and his surgical videos are to be watched for the way in-depth surgery with great skill that he does. And he is everyone's friend, always there to help us out. And we are looking forward to a brilliant year next year with him as President POGS. So I welcome Dr. Manish Mathur. I would also like to welcome Dr. Uma Jaiswal. She's Honorary Secretary, Allahabad OBGYN Society.
It is sufficient.
And
Now,
just few lines. She's also aesthetic gynecologist and obstetrician and practicing since more than 25 years. She is director of Shakuntala Super Specialty Hospital, and she's been life member of FOXY, AMA, specialist in emergency obstetrics, and her special field of interest is cosmetic and aesthetic gynecology in fertility. So welcome, Uma madam. It's truly an honor for us to have you here. So I hand over.
Okay, good evening, everyone.
Dr.
At
Vaishali.
the outset, I have to thank Pune OBGYN Society, Dr. Aarti Minkar, Dr. Meenakshi, Dr. Amol, Dr. Madhura, also Dr. Meenu Madam, Dr. Vaishali for inviting me here. A fabulous talk, the previous one, and a lot of inputs. The only point of contention was, and we have always heard that ketamine makes the pregnant woman Amitabh Bachchan. So that is the only problem in giving ketamine, because I remember there was a study in KEM where they used to use ethanol for prevention or arrest of contractions for preterm labor. And the only problem they found was these labor patients in preterm labor, when they used to give ethanol, And I think similar thing can happen with ketamine. They used to stand on the bed and recite Amitabh Bachchan's dialogue. So that is the only problem, I guess. So without much ado, Uma ma'am, everybody knows Dr. Meenu Agarwal ma'am, and she was the past chairperson of Imaging Science Committee of FOGSI, past president of Pune Obstetric Gynec Society. She is the secretary of ISG, and so many accolades to her name. She is a famous ART specialist and endoscopist from Pune. Just now received the very prestigious Dronacharya Award from ISAR. And Madam has been also instrumental in, propagating endoscopy ART for so many people. She has been one of my inspirations also. And we work together. We've been working together for such a long time. And of course, she's authored so many books, and I personally have a few of them. And she has international publications and Champion of FOGSI Award, Inspiring Gynecologist of West India, Icons of Health Award, and so many more. At the beginning, I would also like to urge all of you, Dr. Ranjana Khanna Madam is here, who's contesting for President, and Dr. Meenu Agarwal Madam is here, who's contesting for Vice President of FOGSI. So kindly, please vote. That is point number one. Please do not waste by not voting. Voting is a democratic right that we have to exercise. And please vote for Dr. Meenu Agarwal Madam. Trust me, and with the force that I have, because I've seen Madam work, with her at the helm at FOGSI, so many things will happen, not only for our patients, but also for all of us, and also for juniors who want to aspire becoming like her. So please vote for her. And today she is going to speak on male infertility, something which probably a lot of people who practice infertility also find it difficult to digest or propagate. And for people like me who hardly do much of infertility, but sometimes the basics of male infertility do come in front of us and for us to, manage. So that will be Madam's talk. I hand over to my co-chairperson to, further introduce and request Ma'am to start her talk.
Thank you, Dr. Manish, and thank you, Pune Obs and Gynae Society, for having me over here. Good evening, everyone. After a very good talk by our senior, Dr. Veena Gupta, I request Dr. Meenu Agarwal. Dr. Manish has already spoken about her so long. Without wasting much time, I request Dr. Meenu ma'am, please deliver your talk.
Thank you, Uma Madam. Thank you, Manish, for your kind words. I'm really, really, really humbled. And Manish is one person, all of us in Pune or everywhere, we look up to him. Whatever he touches, it turns into gold. It's like that. So he's doing wonderful endoscopic surgeries. He's also, of course, a very good medical legal expert. And I think you name it, and he is good at that. So that is very, very important for all of us at Pune OBGYN Society. We are very lucky, very, very lucky to have him with us in our city. He is the pride of Pune for us. So thank you very much. And so today I shall be talking a little bit about male infertility, beyond ICSI. So male infertility means ICSI. It is not that. So let us look at what are the various options, what all we should do before we go take the patient for ICSI if required, and what are the other options even in cases of azoospermia, where the male can become a biological father to a child. So it's a huge problem, we understand. In fact, when we used to study, we were told that 30% are because of female factor, 30% are male factor, 30% both, and 10% unexplained. And I don't know, Dr. Uma, will you agree with me that now we are finding at least 30-40% unexplained. Unexplained is much more than even male factor or only female factor. So many patients are coming with unexplained infertility. And then we are also finding that even in unexplained, male factor is important. So we need to investigate. Even with the normal sperm count, there are tests which we need to do even in unexplained infertility. So first of all, when we give the container to the husband, two things. One is वो wide bore का होना चाहिए. Narrow container if we give, it may spill out and we may not get the complete sample. Second thing is it should be labeled well. अगर लेबल्ड करेक्टली, नॉट वेल, लेबल्ड करेक्टली, जैसे वो गुड न्यूज में था तो सैंपल गॉट एक्सचेंज्ड, तो इट इज इट शुड बी, दैट इज वेरी वेरी इंपॉर्टेंट. देयर आर witness programs now installed in many high-end labs, but if you don't have a witness program installed, then it is a good idea to label it, keep the label inside and outside, and andrologist should know that this gentleman has gone for the semen collection. And place where he has to keep the sample also should be mentioned in the collection room with an arrow. Otherwise, they leave it anywhere and then also it can get exchanged. Now, suppose a gentleman comes with a report of azoospermia. It should be done at least 2 times. एक बारी किया, 1 month के बाद twice. If 2 reports are showing azoospermia, then it could be pre-testicular, it could be testicular, or it could be post-testicular. So there are three reasons we have to broadly divide. Now, then we divide into 3. Suppose we have a gentleman, he has 2 reports of azoospermia. First thing, what we have to do, first thing is we, of course, talk to him. Sometimes they are little feminine, they don't have much beard, they may have a history of low libido, or they have low libido and then they have taken some injections, so libido is fine, the fertility is not good. So these are the low testosterone hypo patients. So wo OPD mein aake you can make out that it probably could be hypo with a report of azoospermia. Second thing what we have to do is we have to do a clinical examination. Clinical examination again is very, very important. Just make the gentleman lie down, cover the penis with a whole forceps sheet, and just hold the testes between your thumb and 2 index finger. If the testes are normal in size, no varicocele, no hydrocele, no inguinal hernia, normal size testes, it is more likely to be an obstructive azoospermia or even pre-testicular azoospermia, and you can just rule out testicular cause by checking the size of the testes. If the testes are small in size, sometimes they are just peanut-sized testes, then you know in your mind that I'm doing all the tests, but this is probably the gonadal or the testicular end organ cause that we are dealing with. So, wahi par patient ka, you look at the patient, you do a testicular examination, half your problem is at that point of time your diagnosis is made. However, you send the patient, what other investigations we need to do? Very, very important investigation, FSH, LH, testosterone, thyroid test, prolactin. So these are the basic investigation that we need to send that gentleman for. And a scrotal ultrasound. Now, suppose we have done the semen test at our center, or he's come with the report, but look at the amount of the sample. Suppose it shows only 1 ml. Or less than 1 ml, then keep a possibility of a retrograde ejaculation. That means the sample is very low in volume. Maybe he ejaculated retrograde. So ask him to pass urine, give the urine sample, take the urine sample, take a drop, put it on the slide, put a cover slip, and look at it under the microscope. You may find sperms in the urine. And at a later date, you can give him alkaline syrup to drink, collect the urine post-ejaculation, and you can freeze those sperms. So now, what do we do in hypo? Suppose we have done FSH, LH, prolactin, the thyroid. FSH, LH is low. Testosterone is low. That means he is hypogonadotrophic hypogonadism. Clear cut, low FSH, low LH, low testosterone. They may also have low libido, for which sometimes they may take testosterone injections. So the testosterone injection will actually cause a negative feedback. So libido will become better, but he will become infertile. So we need to take good history of having taken any testosterone injections from him. So, or even patches or even gel, all that sometimes they are taking from those Ayurveda doctors. They also give testosterone gels. Now, we need FSH. So if the FSH is high, LH is high, testosterone is low, that means it is a gonadal problem. because FSH, LH both are high, but testosterone still is not going up. That means it is the testicular problem. So these reports can give us a lot, to understand what could be the cause of these problems. Now, if he has severe oligospermia with raised FSH, poor prognosis for spontaneous conception. However, these patients we can still get sperms with TISA, TESE, micro-TESE. So all those options should be given to the husband, that these are the possibilities. Again, as I said, if the testosterone levels are low, FSH, LH is high, again, severe degree of testicular damage, and we have to keep in mind. If the prolactin levels are high, sometimes you get patients with sexual dysfunction. So they have less libido or more of impotency with high prolactin levels. You treat the prolactin levels, immediately the potency is improved. So that is again, and it will indirectly cause infertility. If he is not having sex, so it will lead to infertility. So as I said, low FSH, low testosterone, hypo, high FSH, low testosterone, primary gonadism, and then post-ejaculatory urine examination for men, where you find the urine, the semen volume is very, very low. So that sometimes can be a retrograde ejaculation. What are the other tests that we can do for the husband? Suppose he's oligosteroteratospermia. What all can we do? One is the karyotyping. Karyotyping, it can be Klinefelter, not uncommon at all. And it can also be the, there is a deletion at the AZF point. Or we can do a DNA fragmentation. So DNA fragmentation, again, it just cost 4,500. I mean, not just, but it costs 4,500 rupees. So a very simple test to do, we can do a DNA fragmentation. If the fragmentation is more than 30%, that means it is probably the mitochondria is not working. So IVF में क्या होगा, 3 days तक एम्ब्रियो अच्छा ग्रो होगा, उसके बाद ग्रोथ अरेस्ट हो जाएगा. Why? Because there is no energy. The mitochondria is not working that well. So that is one. And secondly, patients where have first trimester losses, blighted ova hai या first trimester losses hai, there also we should look for DNA fragmentation. I have had patients where the patient they come with the preconceived idea कि egg में ही problem है, तो madam do donor egg but do something. But we should also look at the DNA fragmentation even if they are for donor egg. So that is again very, very important. And before we start with any kind of treatment, very, very important is to give them psychological support. That sperm is only for the reproduction. So if the sexual dysfunction is okay, they don't need to feel let down by nature, by God, by anyone. There are options, there are possibilities that they can father their own biological child. So how do we manage the medical management? So if the prolactin levels are high, of course, we can give Caberlin once in a week till we get normal prolactin levels. Agar motility kam hai, sometimes counts are okay, motility is just okay, not very good. You want to do IUI, but you want to improve the motility. So those are the cases we can put them on clomiphene citrate 25 milligram per day for 3 months and repeat the test after 3 months. Letrozole, another molecule, can be used 2.5 milligram per day. If he is obese, then we can go for 5 milligram per day for 3 months, or anastrozole 1 milligram per day again for 3 months. Antioxidants are, of course, for mitochondria. For me, any couple walks into for IVF, both husband and wife are put on antioxidants. Many of them are smokers. Even if they are not smokers, sometimes they have a high DNA fragmentation rate. They're diabetics, they're obese. So all these things we have to keep in mind. So antioxidants, then it can be ester xanthine, it can be coenzyme Q10, L-carnitine, lycopene, zinc. So it is like, like we get a garam masala, we put everything in it and we just put 1 teaspoon of garam masala. Same way, pharma companies are actually helping us. So they put everything in the right proportion, tell us, okay, ye capsule per day dene ko bolo. And we are happy that all of these are there, what individually have been proven to be good for improving the sperm motility or the sperm count. However, one thing we have to keep in mind that they will not improve the sperm count to give a spontaneous conception. Like if I take vitamin A, my specs will not go off. I still have to wear my specs. It might improve my vision little bit. So same way, it might improve the sperm motility quality better for ICSI, rather than thinking that it will give us a spontaneous conception, especially in severe types of oligoasthenoteratospermia. Then we have patients with hypo. Now, hypo means FSH is low, LH is low. So when we say LH is low, LH is producing the testosterone. And we also understand that testosterone, intratesticular testosterone, is also helping for increasing the FSH and for the spermatogenesis. So what we can do in hypo patients, start only with HCG, which is a surrogate marker of LH. So HCG 2000 to 2000 available nahi hai, so 2500 every week for 2 months. 2 months ke baad we do the semen analysis. If we find good sperms, then we can freeze the sperms and then we add HMG to him or FSH to him. So that is or in a severe hypo, we can even start both of them together. So HMG, Monday, Thursday, say 150, Monday 150, Thursday, every Friday he will take SCG. So these are the 2 options that we have. Either start with LH or SCG, 2 months, then add HMG, or in severe cases, we start both of them together. अभी ये कितने टाइम तक देना है, how long to give? Expensive, per month 30,000-40,000 he is spending. We must counsel him beforehand. It may take 1.5 years also for us to see the sperms in the semen sample. Although we do the sperm semen examination after 3 months or 4 months, however, for everyone who's listening to this talk, if you find sperms, आपने 4 months के बाद test किया, आपको कुछ 5 million sperm दिखा, freeze those sperms, because sometimes it can be, बाद में it again goes down. So that can happen. We have seen in our practice. So whenever we find sperms, we must freeze the sperms. So this is how we use gonadotrophins. Both FSH, LH high, testosterone low, testicular volume low. I said primary failure hai. But if they are low, in hypo, FSH is low, LH is low. In failure, their FSH, LH are high. So that is how it should be divided. And now, just 1 minute. So now how can we also retrieve the sperms surgically? Just 1 minute, I'll put my laptop for charging. 1 second. Yeah. So how can we retrieve the sperms in cases where we see a blockage? So simple है, blockage है, मनीष तो 1 second में ही कर लेगा, तो उसमें we can do PISA. Just palpate head of the testis, put a needle there and aspirate. Very, very simple, and you will get millions of sperms if it is a obstructive type of an azoospermia. Earlier, I used to call an urologist to my clinic to do it. However, it is very difficult to match the timings of anesthetist, embryologist, andrologist, urologist, myself, patient. So, abhi I do it myself. Very, very simple procedure. Just take a tuberculin syringe, take some semen sperm media in that, and just go at right angle, or even you can go tangential, the scalp vein, and we just puncture the testis, hold the testis, and just create a negative pressure there. Just create a vacuum, keep on puncturing that, and then we, when we come out, the seminiferous tubules come out with it, and these seminiferous tubules are then picked up with two tooth forceps and then just pulled out. It comes like it's a rassi aati hai, placenta aati hai, it just keeps on coming, and then just put it in the dish and give it to your embryologist to check up. So this we already showed. So this is how much sample we can get with just one puncture. This is an 18 gauge needle, and you can see this much seminiferous tubules we can get just with one needle puncture into the testis, no stitches, no cut, nothing. And this is then given to the embryologist, and the embryologist or the andrologist then teases this sample, because these are seminiferous tubules. So you have to break the seminiferous tubules. The sperms will swim out, and then take a drop, put it on the slide, cover it with a cover slip, and place it under the microscope, and then check it. And if we are lucky, then there is a possibility that we can get enough number. This sample is in a PISA sample. So PISA sample, we can be very, very lucky to get very good quality sperms. Then sometimes we can also do TESE. TESE is like a testicular biopsy. So isko sirf testis ko, but when we open the testis, it should be the blade, sharp edge should be facing the sky. So upar ki taraf, and then just open it, then open you see this is the capsule of the testis. Again, open it, just pull it up and open it, and then take atraumatic forceps, just take the tissue, put it in the dish, and give it to your embryologist. Also send it to the lab, because it is also same as testicular biopsy. So you get a documented report from your whichever lab you are sending to. And then last is the micro-TESE. In micro-TESE, we actually open the testis, completely open the testis, and then with the help of the loop, you look at the areas which are dilated. So this is why we think that there is a focal spermatogenesis. Whenever the testes are damaged very, very badly, still there can be focal spermatogenesis at some places, which can be picked up with the help of a loop. And then those seminiferous tubules are then picked up with atraumatic forceps. We had one patient where we got only one sperm on TISA, micro-TESE, single sperm we got. And the wife was also 35. Both were doctors. Very poor AMH, got surgical management for male infertility. And if there is something we need to discuss, we can discuss. Thank you very much.
Thank you, Vinima. This is a very, very comprehensive, very practical talk by you, delivered by you. Trust you have taken care of. We know, everybody knows 40 to 50% rate is unexplained infertility, either male or female. So you have starting from the very practical, how you collect, which container to be used, where to be keep, how to test, and very important. And every time we should not go for testosterone, not jump up. You have to diagnose clearly and then treat them. Thank you so much. So very good.
Thank you, ma'am. Thank you, ma'am.
Fabulous talk, ma'am. Just one query which always comes to my mind used to come from postgraduate days. So when there is an obstruction, is there any role of vasography or some role of some surgery where we can bypass or clear the obstruction?
Yeah. So if it has been a vasectomy has been done for the husband, in those cases you can do a vasography, see where the obstruction, where this, and you can do same like what we do for the tuboplasty. So that can be done. But if it is a congenital absence of vas, then go for directly go for the.
And for the varicocele, what are you doing?
No, see, varicocele, earlier we used to say if it is a grade 1 or grade 2, that does not harm. Grade 3 and grade 3 operated. But now when I have grade 3, grade 4, my the person tells me, madam, don't operate because do ICSI. he says कि इसको operate ही मत करो. So now the neurosurgeons have also changed their thing. Now they don't want to operate even on. However, if we operate on them and give them enough time, suppose he's only 29 and she is 25 and he has grade 3 varicocele, I think we can operate on him, wait for a couple of years, she can spontaneously conceive. If
Minimum
she
6 months. Minimum 6 months.
then it takes time for the sperm count to come back.
Yeah.
Then it's better to go for ICSI straight away. Yes, Manish, that was and Uma madam, very good question. Yes, thank you.
Thank you so much, ma'am.
Thank you,
I
ma'am.
think we have to sum up because everybody is getting late. Thank you, Pune Obs and Gynae Society, Dr. Meenu, ma'am, Dr. Vaishali, Dr. Madhura, who is talking with me and asking for the CV. I have told that we are from Allahabad Obs and Gynae Society, not from Prayagraj, because Fox is there. Thank you so much.
Yeah.
Thank you so much.
Now, Allahabad is called Prayagraj. No more Allahabad, madam, is it?
No, but society name is Allahabad Obs and Gynae Society.
Okay, okay.
It is a registered lab by the name of Allahabad only.
Okay.
Thank you so much. Thank you, Shubha ma'am, Kumkum ma'am. Dr. Manish, you want to say anything?
No, thank you. Just thank you. Fabulous talks and good take-home messages. Cutting edge webinars, I think, are very good because they are straight to the point, very practical, and they stimulate you to read. So now I am stimulated to read few things which I heard today. So that is the best part. When you are stimulated to read, I think that is the best message which goes into your dura mater or gray cell. So that is the best thing.
And Manish, we can speak directly whatever you want to ask, we can ask them. The speakers are at home. Feel like at home.
तुमच्या बाजूला तुमची नात दिसते.
नातू आहे.
नातू आहे.
So cute. आणि एकदम शांत बसली आहेत हा. बस.
तो ऐकतोय काय बोलतायत ते. मेन इन्फर्टिलिटी.
Very cute. So excellent talk, Dr. Meenu. As always, all your talks, whether hysteroscopy, infertility, laparoscopy, imaging, all are par excellence. And truly, you're the best candidate for the post of Vice President West Zone. And so we come to the end of the webinar. And Madhura, should I propose vote of thanks?
Yes, ma'am. Yes, ma'am.
So it is a pleasurable duty for me to propose a vote of thanks for all the esteemed faculty and all the delegates who have joined today for this webinar. And we are truly honored that Allahabad Society has done this webinar with Pune Obstetric Gynec Society. On behalf of POGS, Dr. Aarti Nimkar, President, Dr. Meenakshi, Dr. Amol Lumkar, Dr. Manish Matsve, President POGS, and all of us at POGS, Dr. Madhura, myself, Dr. Charvape, we would like to thank each and every one of you. Our guest of honor, Dr. Ranjana Khanna and Dr. Archana Verma, who could not join today. Speakers who gave such a wonderful talk, Dr. Veena Gupta, Dr. Meenu Agarwal, who gave the second talk, our chairpersons, Dr. Shubha Pandey, Dr. Kumkum, Dr. Manish Matsve, and Dr. Uma Jaiswal. And a special thank you to our very young, dynamic Dr. Madhura Kerkar, who has been organizing and coordinating the entire process. And thank you to BSV for helping us with this platform. So thank you all. It was wonderful to connect with you all.
Thank you.
Thank you
so much.
Thank you, Vaishali, for coordinating, and it's such a big job. Thank you very, very much. Madhura, Vaishali, Charu, I think we are doing such a wonderful job for these webinars. Sandhya, Samita, thank you.
Thank you.
Yes, thank you.
Yes, can we stop the webinar?
Yes.